Welcome to the deep dive. Today we're tackling the endocrine system.
Yeah, that amazing network of glands. It's basically the body's master regulator, isn't it? Controlling growth, metabolism, stress.
Everything. So our mission here is to cut through the complexity. We want to give you the core concepts of endocrine pathology.
Exactly. We're zoning in on the big players.
Yeah.
The pituitary, thyroid, adrenal cortex, and, well, the huge topic of diabetes mellitus. And the key is connecting the dots, right?
Yeah.
Linking the why the disease mechanism to the symptoms you actually see.
Absolutely. Let's start with the basic language. When things go wrong with a gland, you generally see three main scenarios. First one's pretty simple, hypofunction, meaning the gland just isn't putting out enough hormone.
Right. Maybe it got damaged, like by an autoimmune response, or it atrophied because of some drug therapy.
Okay. And the second?
Hyperfunction. Too much hormone being produced. Could be overstimulation, or more often, it's a tumor churning out hormones.
And the sources mention that strained ectopic production too.
Yeah, that's fascinating. Like a lung tumor suddenly deciding to pump out ACTH. It's not even an endocrine gland.
Wild. Okay, and the third scenario, this one's maybe the trickiest, hormone resistance. The hormones there, levels might even be normal, but the body cells just aren't listening.
Precisely. The classic example is Laron syndrome. It's a type of dwarfism. Growth hormone levels are fine, but the receptors are faulty, so the GH signal just doesn't get through.
Got it. And as we go through these disorders, it helps to remember that whole hypothalamus-pituitary target gland axis.
Definitely. It helps classify where the problem started. Primary means the issue is in the target gland itself, think Addison disease, where the adrenal cortex fails.
Okay, secondary means the problem's one step up. In the pituitary gland, maybe an adenoma there causing issues.
And tertiary is even higher, originating in the hypothalamus. We don't need to list every single cause, but knowing if it's primary or secondary is key.
Because it tells you where to look and what to treat. Makes sense. Let's start at the top then with the pituitary, that little pea-sized gland.
Sitting in the cell tertiary, yeah, controls so much. ACTH, TSH, and the one we'll focus on first, growth hormone or GH.
And when the pituitary itself fails, hypopituitarism, it needs quite a bit of damage, right? Like 75% destruction before symptoms show.
That's right. It's pretty resilient. But clinically, when it does fail progressively, the hormone loss tends to follow a predictable pattern. This is where that mnemonic comes in handy. Go look for the adenoma.
Exactly. It helps remember the sequence. GH usually goes first, then LH, FSH, TSH.
And ACTH is typically last. But losing ACTH control, losing cortisol regulation, that's the most dangerous part.
Absolutely life-threatening. Now, about growth hormone itself, somatotropin, it mostly works indirectly.
How so?
GH tells the liver to make something called IGF-1, Insulin-like Growth Factor-1, and that's what really drives the growth in bones and tissues.
But GH does more than just growth, right? It has metabolic effects too. Big time. It boosts protein synthesis, gets fat mobilized for fuel.
Yeah.
But here's the kicker. It actually decreases glucose use by peripheral tissues, so it makes the body more resistant to insulin. Exactly. It's inherently counter-regulatory to insulin.
Yeah.
Now let's look at what happens with too much GH in adults. That's acromegaly.
After the growth plates effuse, so you don't get taller.
Right. The high GH drives excessive IGF-1 production from the liver, constantly. Since the long bones can't grow, the growth happens in soft tissues and membranous bones.
And you can really visualize the changes the sources describe, the enlarged hands and feet.
The broad kind of bulbous nose, the lower jaw protruding, forehead slanting.
The voice deepens too because the larynx gets bigger.
Yep. But beyond the physical changes, remember that GH-induced insulin resistance, that's a huge problem in acromegaly.
Leading to glucose intolerance.
And a really high rate of full-blown diabetes mellitus, the source says up to almost 38% of patients. That metabolic burden, the cardiovascular risk that comes with it, that's often the biggest threat.
Before we move off growth, just a quick mention of precocious puberty.
Right, early activation of the whole hypothalamic pituitary gonadal axis. Before age 8 in girls, 9 in boys.
So they develop sexual characteristics early, and they might shoot up in height initially.
But the catch is, those hormones cause the growth plates, the epiphyses, to close early. So they end up shorter as adults than they otherwise would have been.
Okay, let's shift gears to the thyroid. The body's accelerator pedal, you called it.
Yeah, it sets the pace. You've got T4, thyroxine, which is mostly storage long half-life, about a week. And then T3, triiodothyronine, less of it, but much more potent.
And producing them requires TSH from the pituitary, enough iodine from the diet.
And key enzymes like TPO. The thyroid actually traps iodine, concentrating it way above blood levels.
And their main job.
Boosting the basal metabolic rate, sometimes by 60, even 100%, plus promoting protein synthesis, and it's absolutely critical for brain development in infants.
But there's that other effect, too, the mimicking of the sympathetic nervous system.
That's key for understanding the symptoms. High thyroid hormones feel a lot like being constantly wired, racing heart, palpitations, sweating, fine tremor.
So when the thyroid slows down, hypothyroidism, everything slows down. The most common cause in adults being Hashimoto's.
Hashimoto thyroiditis, yeah. Autoimmune destruction of the gland over time leads to this generalized metabolic slowdown.
And the hallmark physical sign, if it gets severe and prolonged, is myxedema.
Right, and it's non-pitting edema. You can't just push the fluid away like with some other types of swelling.
Why not?
Because it's caused by these hydrophilic, water-loving mucopolysaccharides building up in the tissues. You just soak up water, gives that classic puffy face, swollen eyelids, even a hoarse voice from laryngeal swelling.
And the absolute worst case scenario here is myxedematous coma.
Yeah, end-stage hypothyroidism. To critical emergency, severe hypothermia, cardiovascular collapse, maybe hypoglycemia. And the crucial point for treatment, the source emphasizes, don't actively rewarm them too fast.
Exactly.
Yeah. Because their circulation is so fragile.
Right.
Rapid vasodilation from warming can cause complete vascular collapse. You have to warm them passively, slowly.
Okay.
Now, the flip side, hyperthyroidism or thyrotoxicosis, too much hormone. The most common cause here is Graves' disease, another autoimmune condition, but this time, antibodies stimulate the TSH receptors on the thyroid.
So the thyroid is basically stuck in the on position, pretty much. And Graves often presents with a classic triad, the hyperthyroidism itself, a goiter or enlarged thyroid, and the ophthalmopathy, the eye changes.
Right, causing exophthalmos, the bulging eyes, which isn't just cosmetic, it can cause double vision or even damage the cornea if the eyelids can't close properly.
And just like hypo has its coma, hyperthyroidism has thyroid storm.
Another life-threatening emergency, often triggered by stress like an infection or surgery in someone with underlying hyperthyroidism.
What does that look like?
Extreme symptoms, very high fever, severe cardiovascular effects, heart failure, angina, and significant CNS effects like agitation, delirium, even coma.
And a key treatment point mentioned is avoiding aspirin.
Crucial. Aspirin can actually knock T4 off its binding proteins in the blood, suddenly increasing the amount of free active hormone and making the storm even worse. You need meds that block hormone synthesis and its peripheral effects.
Okay, moving down to the adrenal cortex now. Sitting atop the kidneys, 3 layers, 3 main types of hormones.
The triumvirate, yeah. Mineralocorticoids, mainly aldosterone, handling sodium, potassium, water balance. Glucocorticoids, principally cortisol, for stress, metabolism, inflammation control. And adrenal androgens. Let's look at deficiency first. Primary failure, Addison disease. Usually autoimmune, destroying all layers of the cortex, so you lose all 3 hormone types.
So you get symptoms from lack of aldosterone, like low sodium, hypotassium, dehydration, salt craving.
And symptoms from lack of cortisol, hypoglycemia, fatigue, poor tolerance to any kind of stress.
But the really distinctive sign for primary Addison's is the hyperpigmentation.
That bronze skin, yeah, especially increases, scars, and gums. It happens because with the adrenal cortex failing, there's no cortisol feedback to the pituitary.
So the pituitary cranks out tons of ACTH trying to stimulate the adrenals.
Exactly. And ACTH has a molecular structure very similar to melanocyte-stimulating hormone, MSH. So the high ACTH levels basically give you a tan.
That's a great clinical clue because if the problem is secondary adrenal insufficiency,
Meaning the pituitary isn't making enough ACTH in the first place.
then ACTH levels are low and you don't get the hyperpigmentation.
Precisely. And the most common reason for secondary insufficiency, abruptly stopping long-term steroid medication. The adrenals atrophy because they haven't needed to work.
And when things crash acutely, acute adrenal crisis, it's all hands on deck.
Life-threatening. You hit them with the 5 S's immediately. Salt, saline, sugar, dextrose, steroids, hydrocortisone, support for circulation, blood pressure, and search for the underlying cause or trigger. Okay, now for the opposite problem. Glucocorticoid excess, or Cushing syndrome. Too much cortisol. 4 main causes, right? A pituitary tumor pumping out ACTH, that's technically Cushing disease, an adrenal tumor making cortisol directly, an ectopic tumor making ACTH somewhere else, or the most common cause overall, taking therapeutic glucocorticoid drugs. Yeah. Regardless of the cause, the signs and symptoms are basically an exaggeration of cortisol's normal effects.
And the physical changes are so striking. The altered fat distribution.
The classic buffalo hump on the upper back, the rounded moon face, the central obesity with the protruding abdomen.
But at the same time, thin arms and legs because cortisol breaks down muscle protein.
Right. And that protein breakdown also leads to thin skin, easy bruising, and those characteristic purple striae, or stretch marks, usually on the abdomen, plus osteoporosis.
Other effects, too: hypertension, increased risk of infection because cortisol suppresses the immune system.
And significant mood changes, even psychosis in some cases. It really affects the whole body and mind. All right, our final major area, glucose regulation and diabetes mellitus. A massive topic, huge. Starts with understanding basic fuel economy. Glucose is the brain's preferred, almost exclusive fuel. The liver acts as the control center.
Breaking down stored glycogen, glycogenolysis, or making new glucose from other sources, gluconeogenesis.
And when glucose isn't available, the body turns to fat, producing ketones. Useful fuel, but dangerous if they build up ketoacidosis.
Keeping blood glucose stable involves a hormonal tug-of-war. On one side, insulin.
Produced by beta cells in the pancreas. It's the only hormone that directly lowers blood glucose.
How does it do that?
Mainly by triggering GLDT4 transporters in muscle and fat cells to move to the cell surface and let glucose in. It also promotes storage-building glycogen, fat, and protein.
And on the other side of the tug-of-war,
the counter-regulatory hormones. Glucagon from alpha cells is the main one, raising glucose between meals by telling the liver to release it. But also epinephrine, cortisol, and growth hormone all act to raise glucose, especially during stress or fasting.
So diabetes mellitus is fundamentally a breakdown in this regulation.
Either not enough insulin action deficiency or the body not responding to it properly, resistance, or often a combination.
Diagnosis uses tools like fasting plasma glucose or the oral glucose tolerance test. But the key long-term measure is
the glycated hemoglobin, or A1C. Glucose sticks to hemoglobin in red blood cells irreversibly. Since RBCs live about 120 days, the A1C gives you an average picture of blood sugar control over the past 2-3 months.
Brilliant. Now, type 1 DM.
That's an absolute lack of insulin, usually due to autoimmune destruction of those pancreatic beta cells. Accounts for maybe 5–10% of cases.
And because there's zero insulin signal to put the brakes on fat breakdown,
they're highly prone to diabetic ketoacidosis, DKA. Unchecked lipolysis leads to massive fatty acid release. The liver converts them to ketones, and you get acidosis. DKA presents with that triad: hyperglycemia, ketosis, and metabolic acidosis. Hence the fruity breath from ketones and the deep, rapid Kussmaul breathing to blow off CO2. To contrast that with the other major acute crisis, seen mostly in type 2, hyperosmolar hyperglycemic state, HHS.
Also severe hyperglycemia and dehydration.
Massive dehydration, often worse than in DKA. But crucially, there's usually still just enough insulin floating around to prevent widespread ketosis, so typically no significant acidosis.
What's the defining feature of HHS then?
Profound neurological symptoms: confusion, lethargy, seizures, coma. It's driven by the extreme hyperosmolarity of the blood pulling water out of brain cells.
Scary stuff. Now, type 2 DM makes up the vast majority, 90–95% of cases.
Yeah, this is primarily about insulin resistance. The cells don't respond properly to insulin, combined with a gradual decline in the beta cell's ability to pump out enough extra insulin to compensate.
Strongly linked to obesity, especially central or abdominal obesity, and lack of physical activity. And often preceded or accompanied by the metabolic syndrome, that cluster. Central obesity, high blood pressure, high triglycerides, low HDL cholesterol, and the insulin resistance itself. And the source highlights this isn't just a list of risk factors. There's underlying pathology involving chronic inflammation.
Absolutely. Systemic inflammation seems to be a key driver, contributing to endothelial dysfunction and accelerating atherosclerosis even before full diabetes develops.
And the classic symptoms people might notice, the three polys.
Right. Polyuria, excessive urination, because the high glucose in the kidney tubules pulls water out osmotically. Polydipsia, excessive thirst, driven by the dehydration. And polyphagia, excessive hunger, mainly in type 1, because the cells are starving for glucose even though it's high in the blood.
Okay, let's talk chronic complications, the long-term damage.
Driven largely by chronic hyperglycemia itself and the formation of advanced glycation end products, or AGEs, which damage tissues. We split them into microvascular and macrovascular.
Microvascular means small blood vessels. This leads to retinopathy in the eyes,
which can cause blindness.
Yeah.
Nephropathy in the kidneys.
Leading to chronic kidney disease and failure. And neuropathy, nerve damage.
Right, often starting as sensory loss in the feet and hands. Pins and needles. Numbness. which is incredibly dangerous.
Because you can injure your foot and not even realize it.
Exactly. Then you add the macrovascular complications, accelerated atherosclerosis affecting the large arteries.
So higher risk of coronary artery disease, heart attack, stroke, and peripheral vascular disease, limiting blood flow to the limbs.
And when you combine neuropathy, can't feel the injury, with PVD, poor blood flow for healing, you get the perfect storm for diabetic foot ulcers.
Which can lead to infection, gangrene, and amputation.
Yeah. And infections in general are more common and severe in diabetes. Poor circulation, high glucose-feeding bacteria, and impaired immune cell function all play a role.
Wow. Okay, so we've covered a lot of ground. We've traced how imbalances in the pituitary GH, thyroid, and adrenal cortex create these really distinct clinical pictures: acromegaly, myxedema, Addison's, Cushing's.
And we've seen how diabetes mellitus, stemming from insulin issues, disrupts fuel metabolism across the entire body, leading to both acute crises and devastating long-term damage.
It seems clear, as the source points out, that chronic hyperglycemia is a major driver, especially for those microvascular complications.
Definitely. Controlling blood sugar is paramount. But particularly with type 2 DM and the metabolic syndrome, it's becoming obvious the problem is, well, bigger than just glucose.
You mean the central obesity, the insulin resistance itself, and that underlying chronic inflammation we mentioned?
Exactly. That systemic inflammatory state seems deeply intertwined with the disease process and its macrovascular consequences. So here's something to think about, building on what we've discussed from the sources. If inflammation is so central to type 2 diabetes and its complications, how does that evolving understanding potentially challenge our traditional, maybe overly glucose-focused ways of treating and preventing the disease? That's a fantastic question to ponder. Really gets you thinking about future directions. Well, this has been quite the deep dive. Thanks for joining us.